Hi, Mike Gibson. I'm here with my good friend, Melissa Wood. Welcome, Melissa.
Hi, Mike. How are you?
Melissa, we both have personal stories pertaining to CTA, how it can really impact things in terms of early diagnosis and getting someone on the right path. I was out to dinner the other night with someone who you may know, Gerald Chan, talking about how do we reimagine education and clinical education? And the idea brought forth was we all know the game 20 questions. Well, you don't want to take 20 questions to get the answer. And we need to be teaching people what are the questions you need to ask and the data you need to get there the quickest. You want to ask 10 questions, you want to ask 4 questions. And I think a lot of times we've had some older risk stratification tools, and they're good, but I've got to be honest, they're not great. So I do think we now have some newer tools, some newer imaging tools to get us to the answer quicker. um, I think for you and I both, we both had some powerful personal stories of just for me, I had an elevated calcium score. That led to me being diagnosed with a high LP Lp(a), which I didn't know about. I was on a high dose of Torva and ezetimibe, and my LDL was 70, but yet I had a calcium score that's off the wall. And then we did uh, a CT angio, and then we looked at the kind of plaque that I had, and we did the FFR and everything with heart flow. And seeing those images, seeing those pictures were very powerful for me, in terms of adding on some therapies, adding on a PCSK9 inhibitor to get my LDL down to 19. So I'm very proud to have the LDL of a hunter-gatherer now. And I know you've had some personal stories yourself.
Well, both myself, my story, and then my partner, Dave. Dave is a really, really fit person. And I think it's extremely important for those of us who are athletes and who care for athletes to remember that athletes expose themselves to ischemic preconditioning on a daily basis. And you really can't trust the absence of symptoms in an athlete. And in Dave's case, I noticed pretty much right after I met him that he had extremely prominent Frank's creases, and talked a little bit about his own cardiovascular risk factors, got him to see a primary care physician in Boston, and they put him on a low dose statin. Over the course of time, I became a little bit more concerned about those Frank's creases and wanting to understand risk. He did not have a calcium score, but was being managed per guidelines with statin hypertension management. And then we moved down here to Florida a couple years ago and were able to take advantage of a population health program in our system that allows patients who do not have symptoms to undergo a coronary CT with plaque analysis to assess their individual risk. And then those patients are followed over time. And so we each had one. And in his case, his calcium score was 1600. And where the heart flow technology really helped us immensely was that the initial read was moderate stenoses in pretty much every vessel. And as we understand, there can be significant discordance between the read, the eyeball read, and the AI generated heart flow CTFFR. And in his case, the CTFFR pointed us to the fact that he had severe disease in these vessels and he underwent a cath and cabbage, and today has an LDL under 10. I think when it was under 5, we were like, maybe that's a little too low, but made a huge difference in his case. So really understanding, and interestingly, his low back pain that occurred regularly went away, and his indigestion went away. So, I think we recognize that there is a lot of subterfuge when it comes to managing what we thought was preclinical coronary disease. And so it really opened my eyes.
What is some of the kind of evidence, the science evidence that is emerging with respect to the ability of these kinds of images to improve our risk stratification, say, and like Pacific, and then, the advanced decay study?
Sure. So the Pacific study, in just over 200 patients, compared different imaging modalities, including nuclear stress, CT without CTFFR, CTFFR to invasive FFR, and found that the area under the curve and the accuracy of the diagnosis of significant coronary disease was best with CT and CT-FFR. So that really helped me feel more confident in utilizing CT as a first-line modality in patients that have symptoms. I think we need to really open our minds to what the symptoms might be. We now know the term cardiac and non-cardiac, but I think as cardiologists who are on the receiving end of the referred patient from a primary care specialist or a physician, it's usually the patient with a chest-related symptom. But we need to remember that pretty much anything kind of above the diaphragm, I think, is on the table for a symptom. And, the historical nuances help us kind of figure that out. But really rethinking the way that we understand symptoms, because now we're able to connect the imaging like we saw in Pacific and outcomes with this type of modality. And then advanced DK really looked at both plaque, those in the highest quartile, as well as those with a positive CT-FFR, and showed that the curves really diverge quickly in those that have normal values for both versus those who have an abnormality. And those divergent curves exist now out to about 7 years and really predicting risk in those with either top quartile for plaque or positive CT-FFR. And then the additive value of both of those pieces of information is really profound in helping us identify risk.
Yeah, I mean, we have moved away from just being plumbers to looking at the narrowing, right, on the lumen, to then we hit an era where we began to look at the wall. That's great too, provides additional information about what's in the wall, what's in that plaque. And now we've moved on to the functional assessment. How does all this affect coronary blood flow? So it's been amazing to watch the evolution in our perception from the plumbing model to now this fully functional assessment of the wall and the flow here 30 years later. So I think we're getting there. Well, Melissa, thanks for sharing your story.
Of course.
And thanks to all of you for diving in and listening today.